myself and Representative Johnson, I want to say that I think that we can all be proud of the work that we have done over the last 4 years to improve the Medicaid program and to make sure that all things have been brought out for consideration to improve the program for the constituents that we serve. And I would also like to say that I've been very proud to have chaired this committee for the last 5 years. I want to thank y'all for your indulgence and your confidence. And I think Robert might want to have a few words to add to that at this time.
Well, all I have to say is obviously the chairman had been outside today, otherwise he'd cancel this meeting. But no, we thank you all for being here, and we have been accused of being real busy and wanting to know too much. But this is part and parcel of what we do, and we think it's very important, and we're going to try to do our best to move this along and find out as much as we can and get something good done. Thank you.
Thank you, Gentleman from Adams. I want to say a word before we get started about what exactly precipitated this meeting being called. The MississippiCan program was a component of Medicaid that is new, and it's just now being implemented. I believe it's into about maybe 10 weeks of its infancy, and there are a lot of issues with the implementation of the program that have been brought to my attention, and many members have come to myself, Representative Johnson, and Representative Holland with questions and issues about the changes that are taking place associated with the implementation of this program. And so what we would like to do with this hearing, the goal of this hearing, is to bring to light a lot of the things that people have concerns about, and to hear from public comment on possibly things that can be done to streamline the implementation or to improve the program for all parties involved, especially the patients. And so at this time, we would like to begin with testimony from the Division of Medicaid and let them kind of basically give us an assessment of where we are, how we got here, and then we'll move along. I believe our assistant Tammy has passed out the agenda. Does everybody who is on the committee have an agenda? Tammy, did you pass out all the agendas? Okay. If you need an agenda, please raise your hand. Tammy will try to get you one. From the Division of Medicaid, we have Richard Roberson and Phyllis Williams. I see down there also Francis Roulon, our trusted media person over here. Thank y'all for coming. And so at this time, y'all are recognized to begin.
Thank you, Mr. Chairman, and members of the committee. Thank you, Mr. Chairman and members of the committee. My name is Richard Robertson. I'm Special Assistant to the Executive Director of the Division of Medicaid. I have with me our Deputy Administrator for Health Services, Ms. Phyllis Williams. And we appreciate the opportunity to come before your group and tell you a little bit about our new MississippiCan program. It's a program for care coordination services, a form of managed care program designed to improve healthcare quality and efficiencies, at the same time lower cost of the program. If you remember, a couple of years ago, back in 2009, in House Bill 71, just as MississippiCan was kind of being born, there were some stipulations and some requirements put in House Bill 71 regarding the program. It required some specific things and put a cap of 15% of the Medicaid population on the program. We're well under that 15% cap. We have about 50,000 people enrolled in the program now, and although there have been some bumps along the road in the last few months as we've gone through implementation, we think over time we'll see some great things from this program, and we'll see some benefits for our Medicaid members, as well as a reduced cost and improved efficiencies for our program. Over 70% of all Medicaid recipients nationally are enrolled in some form of a managed care program. Mississippi is one of just a handful of states that up until recently had no managed care programs. And so we're kind of joining the rest of the nation in that regard and getting Medicaid managed care plans, care coordination plans designed and implemented. You know, one of the things that we think would be good, and the plans can elaborate on this later, we have Centene, Magnolia Health Plan, as well as United Healthcare's plan. Representatives from those companies are going to be here and they'll testify later. They can tell you more about what they're doing specifically. But one of the things that we think will make a big difference is the ability that these plans will have to incentivize the members, the enrollees in the plan, to seek primary and preventive care early on. And that's one of the focus, and that's one of the things nationally that managed care organizations and care coordination organizations have stressed and tried to implement. Trying to improve access, trying to increase utilization of primary and preventive care services. So that's what we're trying to do, and I'll turn it over to Phyllis to give you some more information on the program. Thank you.
Okay, this is a program we have been talking about for a while. I believe last fall we emailed some information to the legislative members, but I do kind of want to hit the highlights, and the plans will get into more details about the services that they provide. But the Mississippi Coordinated Access Network, or MississippiCan, is our care coordination program. It was approved as a state plan amendment through CMS just last fall. The program, services began for the program January 1 of 2011. And the goals of the program are to improve access to the needed medical services by having care management programs. In other words, to help people who don't really know how to access services, they have care managers who can help them access those services. The plans are there to ensure the quality of care. They provide disease-specific management programs, such as programs for people with diabetes, hypertension. And then the third goal was to provide care in the most cost-efficient manner as possible. So the Division of Medicaid went out and to look at the programs nationwide. We issued an RFP, request for proposals. So the vendors that we are using today, Magnolia Health Plan and United Healthcare, were selected through a competitive procurement process. There were a total of 5 vendors who submitted proposals. But these 2 were found to be the most advantageous to the Medicaid program because of the services they offered and how they did that. I will say that in the selection process, cost was not a factor. The capitated payment made to these beneficiaries was developed by an actuarial firm. So the rate is the rate. It's not something that the plans bid. The program targets certain high-cost Medicaid individuals. And I want to tell you how we selected those. The actuarial firm took claims for 2 years and analyzed the claims by category of eligibility. So we looked at the categories of eligibility, those categories where the average member monthly cost, where the cost of those members was above average. So they determined the average point, and then we identified those categories that were above average or our higher cost beneficiaries. And they had to have at least 1,200 member months. Therefore, the targeted groups came out are the SSI, which are mainly an older population, they're disabled, the working disabled, disabled child at home, the Department of Human Services foster care children, and then women in the breast and cervical cancer group. Those were the high-cost groups there. People who are in a nursing facility, an ICFMR, a psych residential facility, anyone who's a dual eligible, in other words, they have Medicare and Medicaid, and any waiver members, whether it's a home community-based service waiver or the Healthy Mississippi waiver. They were not eligible for this program because those programs, the waiver programs, have a case management component in them. So once that was identified, there are certain safeguards. The beneficiaries, the plans must provide all services that Medicaid covers, plus they can't do anything less. They must provide for case management if the beneficiary needs case management. Those case managers and the plans work with the beneficiaries to arrange any health care services, even if it's not a medical service, and I know the plans will speak to that as well. The Division of Medicaid is limited by federal and state law to only provide those services that are medically necessary. But a care coordination plan is paid a capitated rate to provide any service that would support their medical conditions. So they can provide services that the Medicaid program cannot. All of the plans must have focus or programs on diseases like I mentioned earlier, diabetes, asthma, hypertension, obesity, different programs to educate beneficiaries on how to better take care of themselves and to participate more in their own health care, to understand what is happening to them. The program cannot reimburse network providers less than the Medicaid rate. And the CCOs, or the care coordination plans we talked about, we call them CCOs, must arrange any of the services that are necessary. So with all this in place, with CMS approval of our state plan, we began last November sending packets to those Medicaid people who were eligible for the program. They received a nice thick packet in the mail like this. They were given a letter from the Division of Medicaid explaining the program. Okay. A letter that explains the program, tells them just generally about it. It tells them that they either need to select a plan or they can opt out of the plan. And the back of the form, so they don't have to have different pieces of paper, on the same letter, on the back of the form, they can select to opt out or choose a plan. Also in the packet is kind of it's a summary. We took the plans, services, and basic Medicaid services and did a comparison chart. So they could look and see that here's what Medicaid offers in the regular fee-for-service program. If you elect one of the plans, here are the services that they provide. And then we allowed each plan to submit a one-pager summary of their program, plus their provider directory. So that's what they all got in the initial packet. All beneficiaries who got these packets were allowed 30 days to send it back in. If they did not send it back in, then the Division of Medicaid auto-enrolled people into the MississippiCan program into either network, and there was a hierarchy. First of all, they looked at, does this person have a family member who's already enrolled in one plan? Now, remember, there may be family members, but there's nothing in our system that connects them. The caregiver might have applied for them separately, and they're not noted as one family, but it's two separate cases. But that's the first thing they looked at. Second thing was, who is this person's primary physician? And if the person's primary physician was in one plan, but not another plan, then they were assigned to the plan where we could identify they used this particular physician more than others. If there was no way to determine that, all things being equal, it was a random auto-enrollment process. At that time, then, the next stage was they got sent another letter. Oh, and let me back up. In the initial packet, they were also given a prepaid postage envelope to mail their letter back. After the auto-enrollment, they received another letter telling them, we sent you a packet, you didn't reply back, here's what we did, you were in this program, however, you now have 90 days from this letter to decide if you want to opt out. Here's a phone number you can call, and we have staff who will talk with them, work with them. On our website, the Division of Medicaid website, we have a link that's dedicated just to MississippiCan. It has forms on there, it has basic information, FAQs, all sorts of things to educate the beneficiaries about the program. If somebody called and had any problems, we walked through the whole process with them. Total, about 75,000 packets have been mailed out since the 1st of November. As of March 2011, there are 56,242 people enrolled in the MississippiCan program out of approximately 650,000 Medicaid eligibles. Of all the packets sent out, we have received active notices saying, I want to opt out of this program by approximately 18,500 people. That leaves the 56,242. Now, I know many of you heard us say that they have till the end of March, it's the end of the first 90 days, but remember, this is a rolling thing. For those first people who were identified for the program, when we started back in November and sent them a packet and said, choose a plan, not choose a plan, opt out, then the end of March is the end of their total 120 days. They have to make a decision. But everyone, as they are enrolled in the program and enrolled into Medicaid and are sent a packet, they have that same time frame. So it's kind of a rolling thing. Just because, say, someone became Medicaid eligible January 30th, they were identified and sent a packet in February, their initial packet, and so that starts their total of 120 days. It was kind of a rolling thing. So to say that everyone has to make a decision by the end of March is not accurate. It's only those who were in the first mailing. Division of Medicaid has been working with various providers. One thing. After that second 90 days, the 90-day period, and they're locked into the program, they're locked in for a year until a year when we initially send a packet. They cannot opt out for just any reason. Right now they can say, I want out just because I want out. But after that time, they can opt out of the program with cause, meaning their care provides a type of specialist that is not in their network. They have to notify us that we will manually opt them out. It can't be just call and say, I want out. But we have to know the circumstances. Anything that's just cause. There's not a provider in their area. Let us know and we can opt them out. So that we just have to do, that'll be done on a case-by-case basis. Back to provider education, of the last few weeks, we've had so far 18 provider workshops, 18, it's been a long day. We have 8 provider workshops, and over 1,400 people have attended those workshops. We were planning more. We're just trying to get a few more things done in the office, and we'll be planning more provider workshops. Let's see, what else? The monitoring part, we're still working on the final end of the first 90 days. We have staff who are working on monitoring. We have monitoring tools available. Both plans are subject to very intensive monitoring processes. They submit information to us. We keep up with all of the phone calls. We get many phone calls, issues, complaints. We work with the plans to make sure that they respond and then notify us that they have responded. To say everything's been perfect, no. It's with any new program. The first 3 months or so, there's always glitches here, things you learn, things you didn't really prepare for. The plans have both been very good to work with as we have worked to correct those things. Any questions for me?
Lady from Lincoln for a question.
Thank you, Mr. Chairman. I almost asked you to deal, sorry about that. I wanted to know what your plan for expansion of this program, or do you have plans to expand this program past the number that you just gave us?
Since we're limited to 15%, we cannot go over 15%.
So you have no further plans past that right now?
At this moment, no, ma'am, because we can't go that 15%, and we have to look at, there's new people in those categories coming on every month, and we can't do anything to go above that 15%.
Yes, ma'am. And I think think it might be unfair to ask about hospitals because if they want their outpatient surgery paid for, they've had to. I'm just kind of curious how many providers have been certified in the state?
The plans would know that. I don't have, each plan enrolls the hospitals in their network, so each one has a different number, and I don't know those, I'm sorry.
So this is working because you're paying the insurance company payment every month.
Correct, and capitated per member per month payment.
Capitated. So approximately how much is that?
I don't have the numbers with me, it depends. Here's how it's set up. The actuarial firm looked at the actual cost for these categories of eligibility, looked at what the fee-for-service annual cost would be, and looked at it by month as well. So the capitated rates are looked at based on the categories that they're in, the part of the state that they're in, because there's rates for northern, central, and southern. And the capitated rate is, I forget what percentage, less than what the projected fee-for-service payment would be. It's a very long, detailed process. And
It's one of those that
real
we'll never have an answer.
well, I'll be happy to send you the actuarial report on it. It is based off, the capitated payment is a percentage of what the fee-for-service payments would have been.
So you said something else, and you said network providers, if they are in network, the payment, it could not be less than what the Medicaid payment would be.
That is correct.
Okay, so what if they, their doctor is not in network, and that's who they have to see, or there's nobody in network? Then what do they pay?
If the beneficiary's provider is not in the network, but they want to stay enrolled in that plan, then they will need to change providers, or if they continue to go to the same provider who's not in the network, the plan can deny the claim. And Medicaid is not paying that claim either because they are enrolled in one of the plans.
Okay, is there a website where, or someplace, I don't know the website is, answer where you have a list, or somebody has a list of providers that,
Both plans on their website has their current provider listing.
and you're aware that they're using cell phones and debit cards as enticements for beneficiaries to enter their programs? And so if you were on SSI and you were barely making it, you're going to enter that program because you're given $300 on a debit card and a cell phone, and then you are stuck under a program that you can't get out of for a year, and then your doctor won't see you because you have a provider problem. And I'm not sure if you're keeping up or aware of that, but providers are not interested in this program because it's not paying them.
I do understand the provider issues. There are no enticements by the plans. We don't allow the plans to market. Once someone is enrolled in a plan, we do know the plans give debit cards to encourage members to receive preventive screenings. For every particular screening they get, then they get so much on this particular card. It incentivizes the beneficiaries to receive their services. It's not to enroll in the plan because we don't allow the plans to market. The only marketing, the packet comes from the Division of Medicaid.
Okay, the gentleman from Adams has a question, and then the gentleman from Marshall.
Thank you. Gentlemen, you were ahead of me. You mind if I ask, because it's attachment. Thank you. I want to make sure, because this is something that was important to me when we wrote this. The situation that Representative Curry talks about, nobody is bound to stay in this plan. After 30 days, they can disenroll. Isn't that correct?
They can, a total of 120 days, they can disenroll. Yes.
Right. And so they don't have to stay in the plan.
That's correct.
If a provider doesn't want to be in the plan, you want to stay with that provider, just get out of the plan.
Correct.
And Medicaid, you will still be a Medicaid recipient. Is that correct?
Correct. This has nothing to do with eligibility.
Right. So I don't want anybody thinking that if you're part of the 15%, that you have to be on one of these plans. You don't have to be. And if there's a provider, for whatever reason, that doesn't want to participate in it, even though they've been invited, and that's your doctor or your provider, whoever that may be, neither one of you have to participate in the plan. Isn't that correct?
That's correct.
All right, thank you.
Thank you, Mr. Chairman. Well, this is going to follow up with that. I do understand your opt-out clause here. And let me just make sure, you said these are the high-cost groups that these plans are managing, right? Well, they're higher than average in terms of their actual cost.
Correct. The categories of eligibility identified, the average per member per cost in a month is higher than the average.
All right. So you base that on what it costs you all as an agency to administer, correct? Correct.
It's based on the medical service expenditures.
Right, your
Yes, sir.
expenses. So my question is, what is it, if they can't pay any less than you all would pay to the provider, what is it that is allowing them to do it and you all to save the money as a result of doing it? If you pay them and they're still paying you, and they have to pay the provider the same amount that you would pay, where is the cost in it?
It is their care management. It is the fact of identifying these individuals with very intensive medical needs and working with them on preventive measures.
And you all didn't do any of that?
Not to the extent that the plans can do it, because the capitated payment is less than what we would pay for the people, but the plans work with the beneficiaries to manage their care, make sure they're not receiving duplicate services, but getting to the right people so that they receive care before their condition becomes so acute that they end up in the hospital or much more chronic condition.
All right, now. So, all right, I'm just trying to understand it because I'm not the strongest mathematician, but it's just kind of, I'm having trouble adding up words. I understand this. You all did some managed care stuff as well. You tried to at least encourage them to do things that would be preventive in nature as well. Would that not be correct, even with the 80+% that you guys deal with now?
Yes, we encourage the wellness screenings, the annual exams. We do, the Vision Medicaid does those things. But these plans have 24/7 nurse call lines. So if a beneficiary in this plan, wakes up at 2 in the morning and has a fever or they're ill and doesn't know what to do, they can call this 24/7 nurse line and talk to someone.
So now they can offer these extra services in addition to paying the provider with the exact same amount of reimbursement you all pay, and still they make money out of the process?
They'll have to see about whether or not they make money. We just know we pay less.
You pay less.
The capitated payment, the monthly capitated payment is approximately 5% less than what it would have cost Medicaid in fee-for-service claims.
Well, then I'll ask them a couple of questions about that now. As it relates to the doctor-patient relationship, these management teams, these management programs do not interfere with that process, do they? In terms of I heard you say something about they can suggest certain things that normally I would think a physician might. If I go to my doctor, I trust them to tell me to get the right kinds of treatment. I trust them to tell me to do the right kind of things. What level of participation will the management care other than just paying the provider once the doctor makes some kind of determination?
They're here to provide support. So the doctor may have a person present with a history of asthma, but the patient's condition is not being controlled. And it could be because they're not taking their medication or not taking it appropriately, or they might need just more information. They need some education, and the doctor's office doesn't have the staff to stop and educate. And they can work with the plan to identify this person. The plan can go in and provide education materials, talk with the people. It can be the same thing on someone with diabetes. They can provide educational groups to talk with diabetic patients about their diet, about how important it is to monitor.
Is that on computer or in person?
They do it in person and by phone. And they may have other ways. It's just, first ways I know of.
One last. How much money do you all anticipate as a division saving as a result of these management plans?
We're anticipating saving at least the 5%, and then there's some incentives in there to save for the plans, some risk-based sharing concepts that if they achieve certain deliverables, that we will save additional money. But initially, it looks like about a 5% savings for this targeted population. Now remember, right now we've got about 56,000 members. So you're saving 5% of what it would have cost in the fee-for-service program to service those 56,000 members at this point. But that number, you know, can ebb and flow, as people, as Phil was alluding to, people in those categories of eligibility that come into the program will be offered an opportunity to enroll in MississippiCan. So,
Well, it still would be a 5% because it still costs you less.
That's right.
Even if it was more in, you know, people enrolling, because they, rather than enrolling in the plan, they would be enrolling with you. So
That's
it
right.
would be like 5% regardless of the number, right?
yes, sir.
So right now, you don't know exactly what it is, but you just say it's around 5%. Does that mean a reduction in the pins, and does that affect all the matches the federal government does to money and stuff like that at all?
Well, of course, now the match is coming, we get a federal match for the capitated rate. So, you know, it comes in at the regular FMAP rate to match our capitated rate payment to the plans. But we're not paying these claims through the fee-for-service. We're not, well, let me back up. We are still paying some claims for these members enrolled in the MississippiCan program. For example, we had to carve out inpatient hospital, which is a significant cost. So those inpatient hospital claims are still being paid through our Medicaid fee-for-service system. So you've got to, you know, you've got to take that into account. So I'm not quite sure, you know, how to answer your question. We're still getting federal funds. I don't know that there'll be a reduction in that. It logically should be a little bit of a reduction in what we would get, but it's also less of what you have to put up in state share. So we're having to put up less from state dollars, so you're drawing down less in federal dollars.
So if we put the rest of the people in that you all service on some kind of a managed plan, they would be better off in terms of services, we'd be better off in terms of cost, everybody would be better off.
We think so. That's what we're looking at. Yes, sir.
Okay. Listen, I know we have a lot more questions from the committee, but we have a long way to go on our agenda, and a lot of these questions will be answered as more people present down the line. And so at this time, I'd like to thank the Division of Medicaid for their presentation, and if you could, I want to ask you, Phyllis, as we go through this here, and when you come across something that you know that you might be able to answer, could you maybe make a note on that as something that you might want to follow up with at the end of the hearing with the individuals to help the committee grasp some extra clarity? As our next presenter, United Healthcare, Mr. Jeff Drost is coming. I would like to point something out. I want to read from the statute a component that we wrote into the law with the managed care program. It says, the peer committee shall conduct a comprehensive performance evaluation of the managed care program or coordinated care program, which shall include, but not limited to, a determination of any cost savings to the division, quality of care to the beneficiary, and access of care by the beneficiaries. And so I would like to point out that visiting with us today, we have staff from the peer committee. If you would raise your hands over there, they'll be taking notes. I would like to say I know that there are a lot of people who have public comments that they wanted to have noted at today's hearing. And we only have room for so many people on the agenda, but for those of you who have comments or suggestions on improvements to the program or suggestions of changes something that's affecting you specifically, feel free next week to present that in written form to the House Medicaid Committee office. We will compile that into a folder. We will present that to both the Division of Medicaid and to the coordinated care companies, because we're only 10 weeks into this program. We've got a long way to go. Any kinks that can be worked out this summer, the Division of Medicaid needs to know about these issues so that they could possibly address them as they're working through this process. And so, Mr. Drost, if you would...
Please, the committee, Mr. Chairman, if we could have someone much more knowledgeable than me, our CEO for community estate, Tina Gallagher, will be presenting.
That would be fine. Ms. Gallagher, thank you for coming. And You're welcome to begin your presentation.
Thank you. Good afternoon, Mr. Chairman, distinguished members of the Medicaid Committee. As Jeff mentioned, my name is Tina Gallagher. I'm the Plan President of the United Community and State for the Mississippi Health Plans. And we are very pleased to be here today and are honored to have this opportunity to speak with you regarding our program and how we work with the MississippiCan program. A little bit about United, and I want to mention, we did give you a packet of information. There's a lot there. Rest assured, I'm not going to go through it all. I'm just going to hit some highlights, tell you a little bit about our company, about our relationship here in the state of Mississippi thus far, and get into some detail about MississippiCan. First of all, United, if you're not familiar with United thus far, United Health Group is, our mission is to help people lead healthier lives, and all of our mission goals are aligned around that. We here in Mississippi are part of the larger United, which services about 75 million people nationwide with about 78,000 employees. Locally, we consider ourselves to be a local health plan. We have been doing business in the state of Mississippi for over 15 years. We serve a variety of members, including commercial, and last year we were honored to be awarded the Mississippi CHIP program contract as well, so we're about 70,000 Mississippi CHIP members. And then in January, we were awarded the program for Mississippi Medicaid for the MississippiCan program. We do this in 25 states on the Medicaid side, and we service about 3.3 million Medicaid members. So the questions that you're asking about how do we do this, how do we make money while we still save the state's money, is something that we're doing successfully in other states. And I'm going off script a moment, but I thought it was important to maybe answer that question for you, at least from our perspective. One thing that we don't do to reduce our costs is to deny care or eliminate care. Our programs are based upon ensuring that we do the appropriate outreach and identifying the at-risk members, putting them into our case management programs, and actually providing additional services. It's all about the right care at the right cost at the right location. And what it really comes down to is, let me give you an example. If we have a member, one of our chronic members that is requiring a lot of services, maybe to Phyllis's point, they don't know where to go to get these services. So they're getting most of their services perhaps in the emergency room. They might not have a primary care physician or a primary care medical home. The same member might also be taking a lot of medications well over the benefit limit, and therefore paying for these medications out of pocket. In the case of some of our members, they don't have the wherewithal to pay for those medications out of pocket, so what that means is they're not getting these medications. What we do is we look at the overall course of treatment for this member. We have our case managers who are involved in this program, and they do outreach and education to the member. They help them to identify where their best services are. They make sure they have a primary care medical home, connect them with their primary care physician. They follow them through their whole course of treatment. And we allow them to have extended primary care visits. So instead of the 12 visits they're allowed right now, we actually enhance that because we'd much rather have them in the primary care office where that primary care knows all their services and can help us to do that primary care medical home concept at a reduced cost. It's less expensive than the emergency room. Your continuity and coordination of care is better. And you can also look at someone that perhaps has some avoidable admissions that person may be able to help if based upon the case management that we do, coordination of care, and assisting them to better manage their multiple healthcare needs. That's one example of the ways in which we can actually expand services yet reduce costs. Getting back on topic, one of the things that we do in this program is that we focus on the needs of this very vulnerable population. So our programs are built around the needs of this population based upon when we stratify their services, their care needs. When we find members that have a need, they're assigned case management. And I want to say that all of our members are active in case management at some level or another. And we have already in less than 60 days put 1,000 members under our more intense case management, meaning that they're followed by a nurse, either telephonically or face-to-face, which has been a big stretch for us to get that many people in, and that's been our main goal. Our focus, we brought up a command center for our call center. We have a local call center with folks here, local folks answering the phone, answering members' issues. We also have our clinical case management here, which we enhanced greatly for this program. I believe it was 300%, if I'm not mistaken, on our case managers to make sure that we have the appropriate people covering the services. And when we've identified people who've been into case management, we're also following up with them and helping them with some of their pharmacy services, the case I mentioned earlier. And we're getting great feedback from the members. For example, if I might quote one of our members, this is a member we'll call AR. This member was helped by getting pain management and a hematologist. And we facilitated that working with the case manager, helped her with her drugs and her medications. And her quote was, "I so appreciate you and you're working with me through all of this. You have taken so many worries off me." This is what it's all about to us. This is what our job is here. And we know it's new in the program. We know we've got a long way to go. But if we can help these members to have better outcomes and to figure out the system, because one of the problems right now is that it's very fragmented. Members have to figure out, I'm sick, I have a lot of issues. Who do I call? Who can help me? What services are out there available to me? That's really the value adds that we believe we bring to this population of having our clinical staff and our case managers available to help them. Excuse me. We have been doing all the other components of our contract as well. As Ms. Williams mentioned, we are very robustly reviewed and monitored and measured for our performance. There's a lot of safeguards in the contract. And as part of that, we're continuing to build out our provider network. We're working with our local staff. We have a team of local provider relations staff that goes out into the field. We have about 120 local staff here, and should the program grow, obviously we will invest appropriately and with more local staff. Our folks here live here, work here, and invested in the health of the community, and we're very happy about that. We currently cover about 290,000 covered lives in the state of Mississippi through all of our various products. And what we've done as well is we've had over 6,000 member calls per month that our people answering the phone for our Mississippi residents are getting those calls just for CAN. And then also we're doing about 300 town hall meetings with our providers that we've done so far and continued outreach on that. We have WebEx. So again, we know there's a lot of education needs of the members and the providers. We're continuing to have what we're calling member town halls or orientation meetings. We've had 50 thus far. And we get a lot of questions and we get a lot of good information every time we go out and things that we can do to even better enhance the program and help our members. We want to hear what our members' needs are and what we can do to help them.
Ms. Gallagher, the way, whenever I'm trying to speak to people who are not familiar with this program, this is one way that I try to explain how coordinated care works. And I know that this is a stretch and an oversimplification. But if a person has an automobile that they have been given to drive, and every 5,000 miles it is necessary for that person to change the oil and check the fluids, or they'll burn their engine up. And so, even though they might be able to go and get the oil changes with their regular plan, the coordinated care aspect would be the element added of a person who has been assigned to them to make sure, have you checked your oil? Is your engine running low on radiator fluid? Let us send you and make you an appointment at the right place on people who can check this stuff before we have you in the garage having a new engine put in. And so would that be kind of an example of how coordinated care works for the mechanical example of coordinated care?
Mr. Chairman, that is the best analogy I've ever heard, and with your permission, I'd like to use that at other meetings.
You have such permission. At this time, the gentleman from Adams has a question.
Yes, sir.
Thank you, Ms. Gallagher. Some of the apprehension we had at the beginning of the program or we have, instituted by statute. Some of you heard here today, Representative Curry talks about providers not being happy about the program, and I'm sure there were providers who weren't interested in the program at all. I describe it as a matter of education. What are you doing to help providers become aware of how this can help them? Because I'm like Representative Buck. It still begs the question: how do you save money without somebody losing something, either a patient losing a service or provider getting paid less? So what are you doing what do you do to help the provider become more aware of how you can give service to them?
Thank you, sir. There's several things that we do. First and foremost, we have a dedicated provider relations staff here that is out in the field 3 to 5 days a week meeting with providers. And they're working with providers that are participating with us, as well as doing town calls to open it up to anyone who might have interest in our plan. We've done letters, we've done mailings, we have a lot of providers already under our other networks, so we're reaching out to them, even if they're not participating in MississippiCan, we're reaching out to them because we already have a relationship on other products. We obviously would love to have everyone in the network. We know that's not feasible, but we offer it to everyone. We have an open network. Anyone is allowed to enter our network. Obviously, if they meet basic credentialing, having a Mississippi Medicaid license and so forth. We're also working very closely with the Division of Medicaid. As Ms. Williams mentioned, they're doing a series of town hall meetings, and they have kindly invited both plans to participate in those meetings. So when we have those meetings, and the division invites the folks out, we have those meetings as well. And then we also, through our case management again, if we identify that a member is currently receiving services with someone who is not participating, our main goal is to make sure there's no disruption in care. So we'll work with that provider, let them know about our program, make sure they have all the information they need to make an informed choice regarding participation, and allow them to continue to see that member as not participating, and hopefully work with them to get them in the system.
All right, I got 2 follow-up questions. There's 1 or 2, I know there's at least 1 major medical association. Have you called and tried to set up meetings to talk to that association? Mississippi Medical Association, Mississippi Medical Surgical Association, those doctor organizations. Have you sat down and tried to talk to them about what you can do and how you can work as partners?
Yes, we have, and as a matter of fact, our medical director, Dr. Blackson here, is in contact with all of the medical associations on a regular basis, as well as the other associations that touch our members, American Academy, Pediatrics, Family Practice, other associations. Okay,
and my last question, which is what is most important to me, is I want to know, I need you to describe to the committee what do you do to help improve the overall health care and help delivery of care to Medicaid recipients here in the state?
I'm going to ask Dr. Blackson to take that question for me.
She gave me the hard question, Mr. Johnson. My name is Joe Blackson. I'm the medical director for United Healthcare, Mississippi Community and State Plan. That includes the CHIP program and the MississippiCan program. I'm a board certified internist. I'm also an emergency physician. I've actually had the pleasure of working here as the doctor today with a very nice nurse in your clinic. In all seriousness, that's a very good question. It's a very important question. As Ms. Gallagher pointed out, we not only have some very stringent quality requirements to make sure that the quality of care that's provided is appropriate and is up to snuff, so to speak. These are not things that we came up with on our own, but are a function of the Agency for Healthcare Quality, ARC, and with other national entities that monitor healthcare delivery quality. The biggest tool that we have in our toolbox to make sure that the member gets the right care really is the provider, is the physician or the practitioner or the hospital or the DME provider. We do want them in our network. We want them to participate. We want to make this as seamless as possible, but we also want to stress upon them that this is an important step forward for our state, in that it is allowing us to reduce the fragmentation of care that's going on out there. And several of the questions have been, how do you do this? How are you going to pull the rabbit out of your hat and save money? Because Division of Medicaid was paying X amount of money, and we're going to pay United, and we're going to pay Centene a little bit less. Well, the best way to do that is by reducing what really is, in all fairness, some unnecessary or redundant services. And unnecessary services or redundant services or services where a member is going to the emergency department to receive most of their primary care, those are expensive. And if we can reduce those types of utilizations, then we can certainly save money for the citizens of Mississippi. So we want efficient care. We want a patient-centered medical home. We want that member to have, I don't remember who asked the question, but it was, if I go to my doctor, well, we want that member to feel at home with that physician. We want that physician to feel like that member is enrolled in their medical home, and that's where they're going to receive the primary services that they need. And if they need referral out to a specialist, then that primary care model can refer them. They don't utilize the emergency department for, a cold or a runny nose. That's a long answer, and I apologize to you, but it is a little bit of a complex phenomenon, in that we want to make sure that those members have, we throw around this coordination of care, but really it's the old-timey model of you have your own primary care physician or practitioner, and that's the person you go to access the system.
Okay, this is where we are. The gentleman from Adams has a final follow-up question, and then we have 3 questions, the lady from Wayne, the lady from Lincoln, and the gentleman from Forest, and then we're going to go to our next presenter.
I asked about doctors, there are other providers, hospitals, but they're on the list. You don't have to talk about hospitals, they still make their own presentation. But what about pharmacists and some other clinics? Have you reached out to pharmacists here in the state? We're a state full of independent pharmacists. I'm not worried about the Walgreens and CVS. You're not here. But in my hometown, we have a lot of small town pharmacists, and I want to make sure that they're not getting left out of this program.
Yes, sir. Actually, we have what we believe to be a very robust pharmacy network. We do allow and are very open to any willing provider, so we don't close our network. If we have someone who's not in our network and would like to be, we're open to making that happen, and we'd love to have that happen. And we have reached out to the specialty pharmacies. Our pharmacy director, Dr. Bush, who unfortunately couldn't be here today, but is works with the state every day, works with us, has been at our town hall meetings, and I believe has some of the specialty pharmacies and independent pharmacies on speed dial. She speaks with them on a regular basis.
Okay, thank you.